the top of the hour, so we're going to go ahead and get started. So I just wanted to thank you and welcome you to today's Superior Health Regional Coronavirus Disease All-Care Setting Open Sharing Call. My name is Jill Hansen. I am a Care Coordination Project Specialist with Superior Health Quality Alliance, and I'll be facilitating today's call. And just so a little bit of background, for those of you that are new on today's call, Superior Health is actually made up, we're really designed to achieve those broad national aims set forth by CMS. And our 8 entities that make up this would be Medistar in Wisconsin, Stratus Health in Minnesota, MPRO in Michigan, the hospital associations in Michigan, Minnesota, Illinois, and Wisconsin, along with the Midwest Kidney Alliance. So similar to our previous week's calls, we'll have a presentation followed up by a Q&A and then additional round robin sharing. But before we get started and I do my introductions for our presenters, I just wanted to let you all know that today's session will be recorded. And just a reminder to mute your line if you're not able to speak, and unmute when you're going to ask a question, and just say your name and the organization that you're with. If you're a participant that is joining us via just the phone line, just a reminder that *6 is how you will unmute and mute your line. And then just a reminder that we don't want to disclose any personal health information on today's call. And if you're at all having any issues during today's presentation, you can, via the Zoom chat, you can actually reach out to Elena Smith. She is our technical specialist, and she will be able to assist you. As you logged in this morning, you'll notice that there was one polling question. If you want to go ahead and answer that, that would be wonderful. And again, throughout the presentation, feel free to ask questions. And if you have anything you want to share, this is really designed for kind of an all-learn, all-share call. So with that, I just wanted to let you know that today's presentation is titled From the Front Lines, COVID-19 Surge and Response in an Urban Emergency Department. Our presenter is Dr. Bobby Redwood. Dr. Redwood is an Emergency Department Director at Cooley Dickinson Hospital and is also the Wisconsin Hospital Association Physician Improvement Advisor. So today, Dr. Redwood is actually going to share with you sort of that frontline experience from his director level experience and how his hospital has dealt with their surge response, as well as just really giving you some candid information around what it's like to actually be in that ER setting and what they're seeing and what they're dealing with from that patient, from the patients coming in, as well as strategies that Cooley Dickinson has implemented to support their staff during all of this, because it's a stressful time for everyone. And then finally, he's going to wrap up with a—
Jill, can you hear me? You froze up for a second at the end there.
Yes, I can hear you. Go ahead, Bobby.
Wonderful. Thanks, guys. For some reason, there's a little bit of receiving issues on my end, so I will, if I have an awkward pause as I listen to you guys, that's probably why. But as long as you're hearing me well, that's great. So I just wanted to thank Jill Hansen and thank Medistar for the opportunity to speak today. We were sharing before the call, I'm really missing Wisconsin right now. I'm thinking of you all, and I hope you're staying safe out there. As we know, this epidemic has hit the world in different phases. So we were all watching China, and then South Korea, and then Italy, and then New York. And so you may have eyes on Massachusetts right now. We are a hotspot in the nation for COVID. I believe we have the second most cases of the 50 states. And what we've been able to learn a lot from the people who went before us. And so I'm hopeful that some of this information will sound like things you've already been through. Some of this will sound like things you're going through now, and some will sound like things you may be looking towards the future for. And hopefully we can, you can learn from our mistakes and from our successes, and improve your health outcomes in Wisconsin if this epidemic does reach the proportions that we're seeing here in Massachusetts. I'm a very informal presenter, so I want to invite people to chime in with questions. Feel free to derail me. We can dig deep on any given topic. I'm here for you, and the more that I hear from you on what you're interested in, the more I can tailor the content for our audience today. I'll start with just kind of some basic stats of our experience. So I am the Emergency Department Director in a 35,000 visit ED. Our daily census is around 100 patients. We'll get up to 120 on busy days. On slow days, we'll be down in the 80s or 90s. We do have a 19% admit rate and a 33% ambulance arrival rate. So I would say we have a very sick population. And we have a 12-bed ICU with usually 11 ventilators. And we'll talk about how that situation has changed with COVID. In terms of Massachusetts in general, the state has tested 265,000 patients. They are testing 10,000 unique patients per day, and we have 60,000 confirmed cases. So about 10 times what Wisconsin is currently experiencing, obviously a more dense population. And then we've had 3,400 deaths so far. We're in Hampshire County, so we're actually not in Middlesex or Suffolk County where Boston is, and we've seen significantly lower cases than the Boston area in Hampshire County, which has been very useful for us. You may have seen on national news, we did have a pretty severe epidemic in one of our local long-term care facilities. So the Soldier Home facility is a veteran facility, and they've had 74 deaths so far in that facility. So we are looking into local reservoirs like long-term care facilities, jails, homeless shelters, and other sort of close quarters facilities, and trying to learn from that experience and prevent future outbreaks. Obviously, this is sort of a national experience, a national story, and so we can dive into that as well. Our state was pretty assertive about stay-at-home orders. So our stay-at-home order went into effect March 23rd, which was quite early. Our schools were canceled quite early. And we actually have 5 colleges in the area. So in a half-hour radius, we have 5 different universities and a very large student population. And so those all closed on the 23rd as well. And so we sent the students home before spring break, basically. And that was a major disruption to the local economy and a major chunk of our ED volume. And so if you imagine working in an emergency department with 5 colleges around you and you send the students all home, that actually put us in a pretty good spot in terms of having the bandwidth to plan for this outbreak and for the surge that was coming. So I'm going to dive right now into sort of my director level experience. I'll talk about hospital operations, ED operations, and then at the end, we'll talk about actually being a doc. So having my butt in the chair, seeing COVID patients, what we're doing on the ground and how we're coping. And then if we have time at the end, Jill asked me to highlight sort of the behavioral health experience, because that is kind of a unique experience. And so we can dive into individual patient experience at that level and how we're trying to help our behavioral health patients during a pretty chaotic time for them. So first, I would say everything I'm saying right now, it might sound like I'm doing it. I am one of very, very many people. This is such a team effort, such a collaborative effort. And so if you are listening to this and you feel like you're in a vacuum and you feel like you're alone and you feel like you have this on your shoulders, reach out. Reach out to your universities, reach out to your local health systems, reach out to public health. You cannot do it alone. And so this seriously takes a village. And more than a village, I would say it takes disaster preparedness, which is almost a military style command. And so we established at our hospital an incident command team. It's in the basement. It is 12 core people. It's staffed around the clock. And they've got a bat phone, a red phone that goes directly to the mayor. And we have twice daily meetings, 7 days a week. So Saturdays and Sundays included. We have an 8:45 meeting, and then we have a 4:30 meeting. And the structure of those meetings, it's basically at the director level. The 8:45 meeting, we report in what happened overnight and what we're dealing with today and what our challenges are. We ask for resources if we need them. And in the emergency department, I need resources every day. So I do a lot of asking on these calls. And then we circle back at the end of the day to see what's been done. What were we able to achieve? What holes were we able to plug? And what are going to be our ongoing challenges going into the evening? We have an administrator on call 24/7, and that command center is available via a hotline for not just hospital people, but community people as well. And then we have a community care line for patients in the community. So the command center is more for people in hospital operations or regional operations, and then the community call line is for patients seeking resources. I'd say that was one of the first things we learned in the ED was that our charge nurse was phenomenally overwhelmed. We were just taking calls all day. And we talked to the hospital and said, we need people to be able to take these patient calls because the phone is ringing off the hook. And then I would say probably one of the most important parts of the incident command team is actually our predictive modeling. So I know that nationwide testing has been a challenge. If you can get nothing else going, get testing going. And that's much easier said than done. I'll get into that. But testing allowed us to predict what's happening and predict surges early on. And so a lot of our planning has to do with where we're going to be in 2 or 3 days, where we're going to be in 2 or 3 weeks. And if you don't have testing down, you won't be able to predict that, and you're going to get blindsided. And if that scares you, it should. It scared us as well, and it's a kick in the pants to get your local government and your local academic centers, your local Department of Public Health to really start getting testing down early, because if you don't know what's out there, you could be blindsided. For example, our outbreak at Soldier Home, that no one was really expecting that wasn't being reported. And that was a situation where FEMA and national government had to come into a long-term care facility and basically take control of a problem that could have devastated an entire county. So let's dive right into infection control. I think that's one of the early starting points of this. So if you're a facility and you have a couple of cases, or there's a couple of cases in your county, you're probably thinking, how can I keep my employees safe? How can I keep my patients safe? And so obviously there's a lot going on with stay-at-home orders and state level operations. I'm not going to get into that. I'm going to get into facility operations. So one of the first things that we did was work from home. And that was really disruptive. We didn't have enough computers to get people working from home. People didn't have good internet connections to work from home. I would say, you've got to do payroll and HR issues. We're doing disaster credentialing for new staff. There's actually quite a lot of admin support that had to work from home. And I would say that was very challenging, deciding who would work from home, who wouldn't, and in what capacity you would. From an emergency department, I'm obviously coming in for clinical operations. We were trying to do admin operations remotely, but some of the things like building a new respiratory emergency department, which we'll talk about, you had to physically be there as well. Coordinating meetings, how could you make sure that the people who needed to be there to tour the facilities could actually get there? Work from home was a lot of our early discussion. Then we started talking about cohorting patients. Not just cohorting patients, but shutting down non-essential services. So again, we were pretty quick to shut down things like elective procedures, and there were actually state level regulations to shut down a lot of outpatient services. And that's a tough conversation to have, because that's really going to hit your bottom line. And I would say most organizations are hemorrhaging cash right now, and we are no exception. So a lot of our revenue generating surgeries, elective hips, colonoscopies, mammograms got shut down quite early. And what that did was that gave us capacity for extra ICU spaces, extra emergency department spaces, and patient cohorting, keeping sick patients away from healthy patients, keeping positive tested patients away from negative tested patients, keeping asymptomatic positive patients in their own unit. But it obviously has strained the hospital's bottom line, which has ripple effects. We were very early to do masks for all employees and all patients. That decision actually got a lot of criticism, because if you remember early on, and you may still be experiencing this, PPE was precious. And so we thought from an infection control standpoint, it was important to have a mask on everybody's face. Now, there's a lot of talk about infection control and risk. There's a fomite danger here. I think the fomite danger is overstated. The highest risk is when you're symptomatic and when you're coughing. So we started with all symptomatic people wearing masks. We quickly moved to all people in the hospital wearing masks. And we even have an app now where before you go to work, you have to sign in and take a survey of whether you're having symptoms. If you're having any symptoms whatsoever, you get referred to employee health for rapid testing. And then it's basically you have to sign in. We only have 2 entries into the hospital now. We typically have 12. You have to sign into one of those 2 entries with your daily pass that you can go to work. This is critical, because if the providers get sick, if the healthcare providers get sick, then you're just screwed. There is no way to provide care for this volume of patients if your providers are getting sick. And early on in the testing experience, we'll get into testing, but early on in the testing experience, our test had a 7-day turnaround time. And so our ED providers, we were pulling people out of work if you had symptoms of any kind, like a runny nose or a cough. And everybody was just pulling extra shifts. Our 8-hour shifts were flexing to 12s. And so it's another reason to really emphasize rapid testing if that's available, is because your staff shortages are going to be exacerbated if testing is prolonged. Another controversial decision that in hindsight does not seem controversial is a no visitor policy. So we essentially have a no visitor policy. There's a few exceptions, but it's just challenging. It's very challenging, especially when you have demented patients. We are doing so much by phone. Everybody needs a cell phone now. I'm even calling my patients inside the room. So we're calling patients in their ED rooms from our cell phones to sort of minimize that exposure to patients, minimize the number of people going in and out of the rooms. This is a droplet-only disease, so it's droplet precautions. We're not doing aerosolized precautions, and I'll talk more about that. But that being said, it's highly virulent, and so it's kind of like droplet precautions on steroids. Usual droplet precautions are gowns, gloves, mask. We're definitely doing gowns, gloves, mask, N95 when you're having high contact, face shields when you're having high contact. And then if you're doing an aerosolizing procedure like a nebulizer or high flow oxygen by nasal cannula, certainly CPR intubation, it's aerosolized precautions as well. And I would say that has been, I'll get into that later, but that has been a challenge, is sort of keeping the sanity of the staff, because you see people in all different levels of PPE, and really messaging effectively how risky your situation is and what sort of PPE you need. And then finally, we really have had just close coordination with local authorities as well, really the mayor, in terms of infection control, because of all of these moving pieces. So we have a large homeless population, we have a large student population, we had a jail outbreak where they had 20% of their inmates were tested positive in just a period of 2 days. And so the mayor has actually been incremental in terms of creating new spaces. And this is something that probably isn't happening in Wisconsin now. Correct me if I'm wrong, but we have had to sort of take over spaces that aren't ours. So the mayor has taken over hotels, the mayor has taken over student dormitories and said, we are now going to house the homeless population in the Quality Inn. We are now going to have this wing of the Smith College dorms be for COVID positive nursing home patients, and just taking over spaces that really a hospital could never do this. You need governmental control, and you need a little bit of a heavy-handed approach for infection control purposes. And obviously these decisions are not always popular. One of the things that has helped smooth it has been when FEMA took over. So FEMA has monies. They have a specific cost center for when state governments and local governments are using spaces that aren't typically being used. And so we can at least offer some compensation for these businesses that aren't seeing a lot of business right now. But cohorting patients, not just at the hospital level, but actually at the community level, has been a major win for us. And I think part of the reason that we have low cases in Western Massachusetts. We're still a very dense population, but I would say the population has just been incredible about helping us flatten the curve. And that includes the citizens as well as state and local government. I'm going to move on to testing now. And again, if anybody wants to chime in, we just got through infection control pretty quickly. If anybody wants to chime in at any point or ask questions, we can go back to infection control. Testing,
Bobby,
as I said,
I just wanted to make sure you knew people from the state of Michigan and Minnesota are also on the line. We're a 3-state collaborative. So, we've had a lot of the same things happen in the Detroit area that you're talking about, where we had to expand to convention centers and such, because we had a big surge early on as well. So just so you know the context there, yeah.
Oh, thank you, Barbara. No, that context is important, and I actually, that was a blind spot. Michigan, you guys have been a nationwide leader in your infection control efforts, and your governor, I believe it's Whitman, has really taken a lot of flack for doing excellent public health work. And it is such a thankless job doing public health work, because you're not able to show how many lives you've saved. That's part of the reason the predictive modeling is useful, because you can justify some of the hard decisions that have had to be made. So that is really useful to know. Thank you. And I would say that's part of this is governors getting together and states getting together and doing knowledge sharing as much as possible. So thank you very much. And Wisconsin obviously has had their election experience as well. I think we're all talking about November. I don't mean to get into my theoretical waters that aren't specific to health systems, but I think how we do social gatherings that are sort of mandatory gatherings is really interesting as well. Someone was going to chime in?
Yeah, I just wanted to mention that we have been getting several questions. Do you want to take a couple of those or in the chat?
Please, yeah. How about you read the questions out? How's that sound?
Will do. So the first one comes from Belinda. So excellent idea to set up a call center for the ED calls. How did this individual work with the ED staff to help follow up with the family?
Oh, so we have a community call center, which is like registration folk and call people and nurses. And we have a lot of furloughed nurses because they aren't able to be in GI clinic, or they aren't able, it's funny that there's a shortage of healthcare workers, right? But there is not, it's really a shortage of people who are willing to work in the COVID environment. There's not a shortage of nurses right now. We actually have a lot of furloughed people who are looking for work, but they're elderly or have comorbidities or have good personal reasons why they don't want to be on the front lines, but they're perfectly willing to staff a call center or work remotely or something like that. And so I would say that was part of our organizational mission, was to not furlough people and keep people working. And we've had, I would say, moderate success with that. And this was one of those ways that we could provide a community service and keep that going. And the real challenge was updating that person you have staff turnover, you have new people come in, keeping that call center with the most up-to-date information because things change so quickly. And so we're going to talk about testing in a second, but initially we were testing from the ED. We had drive-through testing in the ED ambulance bay. That was too much of a strain on ED resources. Then we got a disaster trailer and we were doing drive-through testing with appointments in one of our big parking lots outside the hospital. That was very effective and that operation is still going. But it took a while for the community call center to start referring people to the trailer. And then we actually had a respiratory infection primary care clinic where we could cohort all primary care patients with respiratory symptoms away from the ED towards that clinic. And so the call center was really the nerve center of where people need to go and how to get people registered. And there was a lot of mixed messages early on in establishing those lines of communication between the call center director, the staff, and the incident command team took some work. And I wasn't the one doing the work. That was a credit to my CMO at the hospital. But that's a great question. I hope I answered it. I actually have the chat room up, so maybe I'll read through them. What is the app? Is the facility type app, or is this open to the community? This is a facility type app, and so I'm trying to remember what it's called. It's through RedCap. I know University of Wisconsin uses RedCap, and it is a cell phone app with 5 questions. If you had fever, chills, cough, et cetera, you have to initial that you are being honest, and then it says you're cleared for work today. Then you enter our door and you show them your app. If you don't have an app, they have computer stations so you can fill it out for the day. They give you a new mask, and we are rationing masks to 1 per day. I'll tell you more about that. Then we have a hand washing station, and then you can enter the facility through 2 determined entrances. We've talked about doing temperature swabs, and we haven't gone there yet because it really backs up people getting into the facility, and we're not sure if it's worth it with our current numbers. If predictive modeling got to the point where we had a lot of concern for asymptomatic spread, we'd probably start doing temperatures. All right. Do employees use a computer to sign in at the entrance? I think I just answered that. Are they given masks? Yes, they are. And someone was wondering where I was located. They missed the beginning. I am in Western Mass. So I recently moved here. I'm a transplant from Wisconsin. I still work with the Wisconsin Hospital Association, but I used to live in Madison, work in Portage, and now I'm in Northampton, Western Massachusetts. And how were you able to staff these innovative spaces for nursing home residents? I was not staffing those spaces. That was done at the town and mayor level. And so we have actually worked with 2 nursing homes that had severe CNA shortages and wanted to borrow from our CNA pool. We have a very strong union presence in Massachusetts. And so that has actually been one of the challenges has been sort of union discussions. Those discussions routinely take weeks and months, and we're trying to do them in a rapid fashion and make sure that everybody feels that they are safe and that their working environment is sort of well controlled and their union contracts have been respected while also changing things really quickly. And I'm probably punching above my weight answering those questions because my personnel issues have more to do with emergency department providers, APCs, and physicians, not so much with CNA and nursing. So that's a lot of great questions. I think I got through the initial ones, and so I will move on to testing and keep an eye on that chat box. We're 20 minutes in, so I think we're doing well. So testing was, as I mentioned, was very slow at first. We had 7-day turnaround times. We were using an independent, I don't know if I'm allowed to say, we were using LabCorp, and it was, they were losing samples, turnaround times were not well. I think it was their services were quite stressed. Our goal was to just get testing going. And so we sort of put feelers out to see if anyone could provide testing for us. Mass General and the Brigham, which are our major academic centers, were not able to. They were overwhelmed with their own testing. Mayo Clinic actually was. And so we started doing courier send-outs to Mayo Clinic 24/7. And we spent a lot of money on postage to get them there and back. But they were able to give us a 24-hour turnaround time. And then we eventually, about a week and a half into it, into late March, early April, got in-house testing. And the in-house testing was, we had data integrity issues at first. The viral transport media was was compromising the validity of the test. And so we had to get new transport media, and eventually we got there. So we now have a 45-minute turnaround test in-house, which has been a game changer. The testing was, like everybody's experience, was everything was on shortage. The vials were on shortage, the culture media was on shortage, the swabs were on shortage. And so we just had a lot of significant shortages early on. At our incident command meeting, we are reporting shortages daily, and we've been able to buy a bunch of stuff, basically. And that is all credit to our lab director, who has really been, there's no coordinated federal response right now, so it's on the state and hospital level to try to buy as much stuff as you can to do resource sharing. And so we report that out at Instant Command on a daily basis, how much we have of all the things we need. The testing challenge, I think, very early on was who gets tested. And so we started off with essentially workers and ICU people only, because we just had so few tests. We only had 15 tests a day, so we were rationing. And then, sorry, I just saw a question pop up. And then we moved on to, as we got more tests, we moved on to symptomatic patients who were not ICU level. And that was really important to know in terms of how to cohort people in our hospital. I would say we were flying blind the first week because we just didn't have enough testing. And we were admitting patients who almost certainly had COVID, and just doing kind of a presumed COVID status and having a clean floor and a dirty floor, but not really knowing who was who. We moved to at-risk populations after that when we had about 50 tests per day. So that was our long-term care facilities, our homeless population, our behavioral health population. And we were testing anyone who came into our hospital, even if they didn't have symptoms, who was an at-risk population, because we were aware that there was asymptomatic spread. The top estimates are that asymptomatic spread's around 25% of it. And so we wanted to keep an eye out for community reservoirs or hotspots in our community. And we did learn a lot from that experience. That's how we found out about the jail population. And then we now have plenty of tests, and we are testing all admissions. We have dramatically broadened our criteria for at-risk populations, and we are starting to do community surveillance testing in the trailer, where people can get drive-through testing if they have an elderly person at home or a person who's immunocompromised, or they're wondering if they can go back to work, and sort of doing broader testing like that. There are 16 antibody tests available. Again, there's not a federal antibody strategy right now. What I understand from our lab director is only 2 of those 14 tests are good. And so we are working on getting good antibody testing. We have antibody testing in-house right now, but we're not using it because we're not convinced that it's valid. And so the sophistication of testing starts with just knowing what's in your community. And then when you're trying to get people back to work and you're trying to get healthcare workers back in their seats, it has to do with who has actually been infected and is better now. So who can go back to work without infecting others. And then, I would say the next level of sophistication would be broad surveillance testing everyone in your community, and then actually doing tracings where you go back and say, okay, you're positive. Well, who have you been in contact with? And we're really not doing that. We're trying to do tracings at the hospital level and trace people throughout the hospital. But we haven't had the testing bandwidth to do that. And I would say we're only just starting to be effective at that at the hospital level. So that was testing. I'm going to get into PPE next, but I wanted to read the questions and see if there's any more questions.
So Bobby, our call usually goes for 30 minutes. So we're coming up to the 30-minute mark. I mean, we could go longer if we wanted. I guess what I was wondering, we'd have a couple of questions that are coming through if you want to answer those.
Absolutely. So I'm your guys for an hour. If I guess I was under the impression it was an hour, so I apologize. And if we want to skip ahead and do key topics, just let me know. I'm here for you. So whatever you need, I'll answer the question now while you think about that. So yep. Did you shut down non-COVID employee call-off methods? During our Emergency Operations Center meeting, we determined that employees opted out of work through multiple venues, some of which left initial gaps in reporting COVID symptoms. Let's see, did you shut down non-COVID employee call-off methods? I'm having trouble understanding that question. What we did do was screen employees for symptoms, and we did have mandatory call-in, so people weren't allowed to say they weren't going to work. But we didn't advertise broadly that you could say you didn't want to work in your clinical environment. But if people had major issues with it, we were letting them opt out and just ask them to be discreet about it. but we mandated that people came to work unless they had symptoms. And it was an honor system whether you had symptoms. I hope that answers the question. And then it's been return to work has been a moving target that's dictated by employee health and infection control. And right now, if you have 2 negative tests, you can return to work. But at first it was just length of time, then it was length of time and 1 negative test. And I wouldn't say we've perfectly hacked that. Do you think that the people who have the antibody are actually immune to infection? I mean, I would say that's nobody knows. CDC doesn't know. I would say there's some degree of immunity once you've had this disease, and that is there's a lot of gray zone. There's a lot of miasma and fog around this disease. We're literally learning new stuff week by week. I just learned, we're just learning now about the thromboembolic component of this and seeing all the strokes from it. And so this is something that we'll have a better answer for in a month. It's a great question. Limited access to tests has been a major concern for skilled nursing facilities. Are you providing these tests to SNFs? So we are. This is the Department of Public Health was initially providing this, and they were doing their outbreak investigations, but their epidemiology surveillance service was overwhelmed, and they haven't been able to do it. And so we've had multiple local outbreaks in our county, and the state says, we just don't have resources for you. Hospitals, you take care of it. So we are spending our own resources to send our infection control people with a infectious disease doctor and with a CNA team or a medical assistant team to skilled nursing facilities to do the outbreak investigations. And we are billing that under the FEMA cost center and hoping it gets paid and assuming some of it won't get paid. How did you coordinate home care? And this is it takes a village. Like, everybody's getting crushed financially. The debt burden after this is going to be substantial. And what we're banking on is that our initial public health investment is going to be worth the money that we save by not having infected people later on, because the ICU cares are also crushing. And so the less that we're spending money on ICU cares, the more that we consider it a good investment, even though it's atypical for a hospital to go out and test in community reservoirs. Are you able to share the names of the 2 tests your hospital is using that you consider to be reliable? I do not have that information. So that's a level of detail that our lab director has that I don't have. And I actually say that information came from an academic paper that I read. And so I can look to get that paper and forward it on to Jill. That number 14 out of 16. Our lab director just did independent research and contracted with the company that she thought had the most effective test and the most affordable test and the best turnaround time. And I don't know what that is, but it's really not up and running now anyways, because we're not convinced that it's good enough. So it's probably not a question I would want to give you that name yet anyways. So we are at half an hour, and I would say the things I have left on my agenda are PPE, surge planning, and then ED level operations, staff wellness, and behavioral health population. I'm happy to stay on and do that from 10:30 to 11, or we could just do some quick hits now if we want to wrap this up. And I will let you guys tell me what you want.
I know there's one.
Go ahead,
One more
Anya.
question. There's one more question in the chat.
In the comment box.
It says, and most people definitely want you to continue, but anyone that isn't able to stay on for the full hour, please feel free to drop off. But Dr. Redwood is willing to stay, so thank you for that. The other question that was left over was, how did you coordinate home care transfers after cover? Did you utilize home care calls follow-up? COVID not cover?
Yeah, I may make some of you guys jealous because the level of investment in Massachusetts was the first state to have essentially socialized medicine through mass care, it's like Obamacare, but it actually has a well-funded public option, or a private, well-funded government option. So we have something analogous to Medicare for All in Massachusetts, and we have incredible outpatient services because of that infrastructure, because we're trying to, the incentives are aligned differently, where we try to keep people out of the hospital. Now, they're not staffed as well as we'd like. That's probably the problem, but they exist. So in our county, we have visiting nursing associates, which is a home health care agency, and they do it all. They will transport patients. They'll get cabs. They will go to your home and do pulse oximetry. They will bring you home oxygen. It's really a sophisticated level of service, and that's how we're able to quarantine a lot of people at home. And hopefully, it's not as successful as I'd like, but keep people out of the emergency department who are COVID positive, but not sick enough to require hospital level resources. I'm reading the questions here. All right, I think I got them all, and please chime in, guys, if I'm missing a question that we really want to cover.
I think there might be one other one on there. How did you transport patients from the hospital to home or SNF to ALF?
Sure. Again, we have community resources for this. So we have medical transport. We've tried to minimize ambulance transport because we need our ambulances for acute cases. And then we are relying on family members in a way that we don't usually, which has been a stress because people need to social distance. And then we're asking family members to step up and transport their family when appropriate. And so cohorting on the home level with COVID is all about who's in your bubble. And most people have sort of a small family bubble. And we say, if you've already been interacting with Uncle Ralph, please have Uncle Ralph drive you. And so I would say it's a mishmash, but we probably have more community transport than other areas of the country because of our emphasis on getting patients into an outpatient environment. And then we've really flexed up telehealth services as well. And so telehealth, we were sort of poised and ready to go for it, but there were a lot of billing issues with the state and it wasn't getting paid for yet. And to the state's credit, they fast-tracked a lot of they basically said, trust us, we'll pay you for these telehealth services. And that got us the momentum we needed to go live with IT infrastructure that we already had, but we weren't utilizing because it wasn't guaranteed that it was going to be paid for. And so I would say that the local government's willingness to support care innovations has also been a boon for us. It's a bit of a different world out here, and I'd say we have the Massachusetts governor has taken the direction of Governor Cuomo in New York and really done sort of military style, like top-down orders. We're going to do this. We're going to do this. And I think it's been perfectly appropriate in this context to save lives. All right, I'm going to burn through PPE and try to get to ED specific stuff. PPE has been on shortage since the get-go. We're short on everything: sanitizer, gowns, masks, face shields, PAPRs, everything. The sanitizer was probably one of the early ones. We've used to like spray bottles, industrial sized spray bottles and tissues where you can sort of spray stuff down. So we ran out of those Virex things almost immediately. We were rationing masks to one mask per 5 shifts for a while. We now have 1 mask per shift. And we use N95 in COVID areas and non-N95s in non-COVID areas. Face shields, we actually had Smith & Wesson, I shouldn't use commercial names, but we had a local company donate like 1,000 goggles. And so we're wearing like firearm goggles around the hospital. And then we have face shields for intubations. And I know the community, again, I cannot overstate how responsive the community has been, but we have these 5 colleges in the area. And so a lot of engineers and smart people got on their 3D printers and printed out things like face shields. The community has been sewing masks. And so we went pretty early. Northampton, my town, actually has a law that everyone has to wear a mask. And that went into effect a couple of weeks ago. And the community already had buckets and buckets of homemade masks. And so the hospital decontaminated the masks. We washed them for people, and then we distributed them to all patients so people could take masks to go home and have masks for their children. The gown issue has been tough. We bought a ton of reusable gowns early on, which has been helpful, but we couldn't launder them quick enough because of shutdown of services. And so we bought a ton of washing machines. So we have a room full of washing machines in the hospital to wash our reusable gowns. But we've been reusing gown from patient to patient, which is like infection control nightmare. But this is rationing and this is scarce resources, and that's what we've been doing. PAPRs have been totally ineffective because of the turnaround time to clean them. This is these wearable spacesuits that you wear. So we have about 10 PAPRs in house, and they're for people whose N95 masks don't fit or for people with beards. And so we quickly told everyone to shave their facial hair. We said, like, sorry, shave your facial hair. And then the people who just can't get their masks to fit right, we have all these different types of N95s, and there are a few people who have to wear PAPRs, but it was really impractical to get them cleaned fast enough. And so I would say that's just been a challenge, is the PAPRs. And we are now in the reuse phase. And so we are reusing all of our N95s where we actually write our name on them. You write your facility on them. They go to a Kmart or like local warehouse in the area, and they go through a hydrogen peroxide decontamination phase. And so I will come to work and there'll be a paper bag with my old masks, and I will put on my old mask from a couple weeks ago that got cleaned with hydrogen peroxide. It's, a lot of this, you have to have faith that your organization is keeping you safe. Early on, there were a lot of position statements from physician groups that was said, can people use home PPE? So, our physicians wanted to use N100 masks, sort of construction grade masks. And the infection control people were really wary of that. They said, we don't have any idea what this PPE is. We don't know if people are using it safely. You could be less safe if you're using your home equipment. But our CMO, I think boldly decided just to let people use it. And we tried to register all of people's home equipment. And it's just really challenging. People want to stay safe. They want to keep their family safe. They're not convinced always that their organization is keeping them safe, because this is weird. It's weird to reuse things. It's weird to enter multiple rooms with the same gown. The union has not been comfortable with it. And I would say that that's been a pain point for us. And I'm glad I'm not the one in that leadership decision making those calls. That's above my pay grade. And so I am following the party line. And I feel safe. We've actually had far fewer staph infections than general community infections. So it's actually protective to be a healthcare worker. It's protective to work in the ED. And that makes a lot of sense to me. If you're working in the ED, you know which patients are sick. You've got them in a gown and a mask. I'm in a gown and a mask. We are washing our hands before and afterwards. And we have negative pressure in our units. If you walk into Trader Joe's or Safeway, if you walk into the supermarket, that person's handling 200 credit cards a day with gloves on. I mean, what's safer? I'm not sure. But I think that being in a healthcare environment might actually be protective. All right, let's see. I got some questions. I knew PPE would generate questions. What is the process when there are no PCPs who are accepting patients and follow-up is needed? Oh my goodness, what a great question. So we did open a respiratory infection clinic, and that's been great. Our ED would have just collapsed without a respiratory infection clinic. So we have an outpatient clinic where you set up online appointments and you can go in and get COVID tested and get a chest x-ray and get an inhaler if you need it. You can get set up with visiting nurse associates for home oxygen if you need it. And it's been a partnership with the respiratory infection clinic. We want them to refer patients to us when they're sick enough for hospital cares, but not when there's a home care option. And that's been a tension that we're navigating, I think, reasonably well. But the first week was clunky. And we got a lot of inappropriate referrals, and we got a lot of, how do we do this? How do we do this? This patient's got a DVT. Why are they in the respiratory clinic? Things like that. And then I would say our PCPs are now seeing patients again. It has calmed them significantly that we have the respiratory infection clinic, and they're getting used to the fact that this is everywhere and they need to see their patients. But it's been a pain point as well, is how do we cohort these patients and how do we get our PCPs to open up services? Different groups have been more willing to do so than others. And it's a spectrum. Like, one group wants full PAPRs for everybody. They want spacesuits for everybody. It can't happen. It won't happen. There's no way for that to happen. And so other groups have just been very open arms about it and say, we understand that we're the front lines and we need to see patients too. And they're doing the same things that we're doing at the ED level in their clinics and trying to do on the ground innovations to keep people safe. We have office buildings that have a PCP clinic in it where the other businesses that are open don't want patients coming in. And sometimes you have to have some hard conversations about all of us sharing this burden together, the burden being infection risk. All right, surge planning. So again, the data is so crucial. You got to know, you can't think about where you're at tomorrow. You have to know where you're going to be at in 2 weeks and where you're going to be at in a month. And you have to be nimble. And that's so much easier said than done. It sounds like I just say that. So this is something that we're constantly working on. I know that Mass General actually released a nationwide predictive model. It was in the Washington Post, and it's state by state, so you can sort of see where you're going and where your levels will be at with different levels of social distancing. And how effective are all of these tools is another question. Obviously, a homegrown tool is going to be most effective. And so we've been able to get that level of data collection, but it takes a small army to do it. And so basically we have three phases of our surge for the emergency department. So we have our typical emergency department, and then we change the endoscopy space into our respiratory ED. So nobody's doing EGDs, nobody's doing colonoscopies. That space is now our respiratory emergency department. And right now we are in Surge A mode. So Surge A is 8 physician hours per day. And these are our peak hours. So it's basically 9 to 5. And what we're doing is we're trusting the respiratory infection clinic to siphon off the low level stuff. The high level stuff is getting referred to the respiratory ED. And then after hours, patients are going back to the normal ED. And then we have a cohorted pod, or a pod, which is seven beds with negative pressure, where we are keeping our after hours infectious patients. The reason we're able to do that, you've probably heard, but volumes are actually down nationwide in emergency departments. That sounds counterintuitive, but people are scared to come in and seek emergency care because they're scared of getting COVID. That is not a good situation to be in. That's a bad situation to be in, but that's a situation we're in right now. The flip side of that coin is the acuity is way up. So our acuity is usually 19% admit rate. We're now 27% admit rate. And it just takes a lot more time to provide patient care. We're running more lab tests on people. We're doing more procedures. And everybody has to gown up and gown down all the time. So it's kind of this really intense level of care, even though our volumes are down. So when you hear about New York, they actually have lower volumes in their emergency departments than usual. Elmhurst, the center of the epidemic, has fewer patients than usual in their emergency department, but everybody's intubated and they're boarding hallway patients on vents. And so it's just a kind of a weird time to practice emergency medicine. Our Surge A flexes up to 16 physician hours and 8 APC hours, and our Surge C is 24-hour coverage for the respiratory emergency department. And the reason we're gatekeeping this is because we want to use our staff wisely. Obviously, we're stretching a lot of our staffing. I am in charge of staffing the emergency department. So we brought 2 physicians out of retirement. We had people who said they want to help out. We had our University Health Services has closed down because the colleges closed down. And now the University Health Services providers have been trained to flex up if the emergency department Surge B happens. And then we had 4 advanced practice clinicians who their plan was to graduate from PA school and join us in the summer. And they were able to sort of get disaster credentialing from the state early, and then we were able to fast track them and get them working now. So we have people who are basically new grads who are going to be working in the summer working for us now. And that's really helped us adapt to this staffing. I've got a question here. All right. It sounds like a long question. It's more of a reminder that we have we have a lot of information for people to access. And so I won't touch that one. What are the recommendations for N95 and gown reuse and storage for home healthcare scaled disciplines related to limited supply and shortage? There is no perfect answer for what are the N95 guidelines. In general, COVID is droplet precautions only, and droplet precaution is not N95. That is surgical mask, gown, gloves, and face shield would be droplet. So they were entertaining the thought that this was aerosolized, and I would say the evidence that this is aerosolized is not very sound. If you're doing aerosolizing procedures like nebulizers, high flow nasal cannula, and high flow nasal cannula is not a non-rebreather. It's like a BiPAP equivalent, BiPAP or intubation. Then we are using aerosolized precaution. And some people say that's an abundance of precaution. Some people say you don't need that level, but we are using that level, and that would include your N95 mask. That's the only real difference there. And so in a long-term care facility, I would think that you don't necessarily need an N95, but I mean, if you have them, that's an extra level of protection. It's really about how much you have, how much equipment you have. A year ago, I would never have imagined that I would even wear the same mask into 2 different rooms. I'm like, who does that? That's just bad infection control. And I do that every day. And we were reusing masks for 5 days. And then there's plenty of resources online in academic papers on how to sterilize equipment with this hydrogen peroxide process, but it is not an in-house process. This is an industrial process where you have it's private companies doing it on a large scale. And so that's a little more than an individual facility could do. It's just a tough question. There's no perfect answer. What I would say is don't take my word for it. Consult your local infection control person and see what your regional standard is based on availability. There's no good answer. All right. In the interest of time, I'm going to dive right into ED operations because this is the part that I find most interesting. These are the things I had the most direct hand in building. In any disaster scenario, communications are the first thing to break down. And so I've got 70 staff and I'm trying to communicate with everyone. You need people to really check their emails. We all quote check our emails. People really need to check their emails. So that's why I would emphasize first is the professional obligation to check your email every single day, even when you're not on, or you will miss something and you'll potentially put yourself or others at harm. We do daily huddles in the ED. We are now doing them 6 feet apart. So we're shouting across the emergency department. It's a little ridiculous. The patients can all hear the daily huddle. But we actually learned that a lot of the way that staff spread was happening, not at our hospital, but in the Boston area, was actually in break rooms and staff spreading in conferences and to each other. And so you have to practice social distancing in your facility as well. We have whiteboards throughout the ED that we're updating regularly with daily updates, because the updates really do come on a daily basis. And our testing criteria and our screening criteria and our PPE criteria literally change. They will change from 8 a.m. to 6 p.m. We're doing Zoom conference as much as possible, and we did by accounts for all of our departments, so we have that capability. And then we're doing frequent journal clubs to try to stay on the medicine of all this. There's a lot of medical updates with this as well, and things we're learning that we are, if you had told me 6 months ago that somebody could be awake and talking to you with an O2 sat of 60%, I would have said your machine's broken. We have the happy hypoxics, people who have been cruising in the community, talking, driving, doing their normal stuff with O2 sats of 60%. They come in walking and talking to you, and we're not intubating them. We're putting them on non-rebreathers and admitting them to the floor. It's crazy. This disease does things that we never would have imagined. So you got to stay up on the medical knowledge, and those journal clubs are often multidisciplinary. So we're talking with our ICU and floor colleagues as well. Our testing protocol, I think I went over that pretty well. Our ED has basically just been trying to be nimble and adapt to the needs of our organization, which without becoming a testing center for everybody. We did have to push back and say, we really need this disaster trailer opened. We can't have our ED flooded with surveillance testing. And then we have workup and treatment protocols. Who goes home, who stays in, what level of care decisions are made. And I would say that patients are basically divided into 3 buckets. There are let's say 3 buckets. There's the worried well. The worried well are either, do I have COVID? I think I have it, but your vitals are good. You're speaking in full sentences. You look great. Or really low level COVID. People who certainly have COVID, they have the usual symptoms, but again, they're functioning well, and their recommendations are to go self-cohort at home. Then we have the patients who need a tune-up. They were the worried well, but now it's a week later, and they're increased work of breathing. They've got beads of sweat on their forehead. Their SATs are still good. Maybe they're iffy 95 area. These patients will send basic labs on. We'll make sure they're not in renal failure. We'll rest them on oxygen for a while, and then we will try to get them home. If it's iffy, we'll try to get them home with visiting nurse services to do pulse oximetry checks. Then you have patients who are sick enough to need hospital level resources. They get this whole battery of tests. So they're getting D-dimers and LDHs and CRPs and all these sort of niche inflammatory tests that we're not usually sending on people to help decide whether they need hospital level or ICU level resources. We have hospital protocols for that are changing, again, quite frequently, depending on how much availability we have in-house. We now have 28 ventilators in-house. We originally had 11. That's sort of a nuanced special discussion, how we got more ventilators. The FEMA ventilators were not great. They have issues. We are using our anesthesia machines. They're not great. They had to be retrofitted, and they have, you have to go in the room a lot and mess with them and stuff. And so we have 28 vents, but we don't have 28 good vents. Luckily, we've really flattened the curve, and we are still in surge A mode, where we're really only using our core ICU and then an overflow ICU. And so we have never gotten to the point where all of our vents have been at capacity, which is incredible. And then other ED innovations, we do have an airway team. So our anesthesiologists, we're not doing elective surgeries. And so they are now in-house 24/7. And when we need to intubate, we can page anesthesia, which has been very useful. It was clunky at first. The anesthesiologists had been used to OR situations, and they hadn't done a lot of emergent airways recently. So we had to do simulations and walkthroughs and sort of make sure that people were using our protocols, using the drugs that we had in the ED, the basic quality improvement work that comes with doing a care innovation, but just done over a matter of hours and days, not over weeks and months like we're used to. And then we are, I talked about staffing a bit. We are also, dealing with just the stuff you read in the news, the novel therapies. So we are moving away from hydrochloroquine. We're moving a little bit towards steroids again. Steroids were out. Now maybe they're back in. Antivirals that have all been under investigation. There was a lot of news yesterday about remdesivir, and that seems to be gaining heat. So it's a constant conversation with the medical literature about which of these therapies are effective, and we're adapting our protocols really based on Mass General. Harvard's been kind of guiding guiding regional protocols. And I'm sure UW is doing something similar, and University of Minnesota and Michigan as well. Sorry, I don't mean to be Wisconsin focused. And then the things that are pretty tried and true are a fluid sparing strategy for COVID. So Surviving Sepsis campaign, complete opposite. They said fluid restrictive for COVID. Awake proning and having people do tummy time and lay on their sides. And then we actually have a trial going for convalescent plasma, where you take people who have already been infected and transfused plasma. That's very much a trial that is not yet strong evidence, but we're a site for that. So that's one additional therapy option that we have. And then I think my main role as emergency department director has been keeping the calm. People are freaking out. They're freaking out. And you cannot provide patient care if you're freaking out. We have to take our own pulse. We have to convince ourselves that it's safe. And, soldiers go to war. Doctors, nurses, techs, we go to a hospital. That's what we do. We go to long-term care facility. We protect the people. That's what we signed up for. That's our job. And it's a lot of pep talks. And it's not just doctors, nurses, and techs. It's the cafeteria staff. It's essential services. It is the custodial staff. And so I do a lot of gratitude. I do a lot of coming to work and thanking every person I see. I do a lot of writing little cards for the people who made this day special. The amount of pizza flowing into our hospital is off the charts. And so the community is keeping our staff fed. Local artists are creating T-shirts for us and posters for the staff. And I think that's probably, from a director level, almost an equal challenge of everything else, is just keeping morale up. I'm going to dive into that really quick. ED interventions. Yep.
We've got about 4 minutes left, Bobby, and we do have a couple of questions in the chat. So I'm wondering if you're able to answer those at least first.
Absolutely. We'll table the provider experience and the staff wellness, and we'll do questions instead. So
okay. So we've got. Yep. Is it recommended that the N95 and gown are left in an open bag in the home versus the field staff member taking into their vehicle?
Oh, great question. I don't know the answer to that. I can pass on what we're doing, which is based on our infection control people. We have paper bags in a communal area, and at the end of your shift, you put it in the paper bag. That's what we do.
Okay. Do you have?
I don't think these things are evidence-based. I think these are based on your available resources.
Yep. And you also spoke about, with the social distancing for your huddles. Do you have any resources that demonstrate the importance of social distancing by staff in break rooms and conference rooms?
Oh, so that knowledge came to us from we're a cohort of 13 hospitals, and we have a mothership, and the mothership shared that on one of our calls that the Boston hospitals were experiencing they were doing tracing of staff. When staff got sick, they were doing tracing, and they were finding that the number one cause of staff infections was actually break rooms and eating together. And so I don't think that's published literature. I think that's anecdotal experience from a major health center in the middle of the epidemic. So verbal reference only. I haven't done a Google search for it, but that's where I would start, to be honest. Sorry about that.
Nope, that's okay. We have some PPE we're able to donate to our post-acute partners, but we are struggling on how to prioritize these requests, skilled nursing facilities versus home care versus long-term care. So any guidance you have around sort of how you prioritized, if you're sharing that?
I'm guessing, because this is not my area of expertise, I would say we are, the level of resources available to the local long-term care facilities depends on how well funded they are. We know the ones that have private insurance and that have they might have on-staff infection control people. They're not going to get anything from us. They've got to fend for themselves. And then we know the ones that are basically all Medicaid and dependent on volunteers and donations, and they're going to get lots from us. And so I don't allocate resources. That's again way above my pay grade. The incident command talks about how to share resources. But I imagine they're sort of doing it on a need-based basis. It would be what I meant. I'm like conjecturing here. So the long answer is I don't know how to do that, but I think that the lesser funded long-term care centers are getting more love from state and local government and from their regional hospital partners, just for cost purposes. That would be my guess.
Okay, we are actually coming up on the hour, and I know we've extended this, so I just want to be cognizant. I just wanted to thank Bobby for being on the call today. I wanted to thank everyone for a great discussion. And I think it lends to, Bobby has a lot more that he could share, so wondering if we could potentially have him come back and kind of do sort of that support component that he didn't get to touch on today.
Yeah, I'd be happy to do that. I have an 11 o'clock call. It's my time. So let's just table that. And I think that's actually, I bit off more than I can chew. And that's a discussion that on its own has merit. And if we do it in a week or two, you guys will, unfortunately be deeper into your epidemic, and it might even be more pertinent.
Okay.
So obviously I hope the curve flattening happens, and that's not the case. I hope I'm wrong. So. Yeah.
Okay, so, and everyone, thank you for being on today's call. Just a reminder, next week, we're actually going to have our talk about focus on trauma, self-care, and burnout. So again, thank you for being on the call, and we appreciate you taking time away from your busy schedules, and have a great rest of your day. Bye, everyone.
Thanks, everyone. Bye.